So yeah, you can go ahead and start now. Thank you.
Hello, everyone. Welcome to this first day of Europe Liberty Forum 2021. My name is Roxana Nicula from the Foundation of the Advancement of Liberty in Spain. And I am going to try and co-moderate and be also a panelist for the first part of this session, talking about defending healthcare in Europe, new approaches to an old system. Our colleague from the Institute of Economic Affairs, Christian Nimitz, who is going to moderate the rest of the panel, is joining us shortly. So I hope that we can make this panel interesting and useful for all of us in all the think tanks defending free market principles for our continent when it comes to defending our healthcare. So let me start by saying that this panel is going to cover the regulation of the healthcare industry in our continent as a consequence of what has happened with the pandemic, but not only, because remember that our system was already having failures before the pandemic. We are going to talk about red tape. We are going to talk about all these kind of regulations that put barriers instead of leaving initiatives, private initiative to give solutions to our healthcare. Of course, we are going to talk about the development, production, and return of medicines, doctor-patient relationship, health insurance, professionals, hospitals. We are going to talk about whether it is interesting to centralize in the middle of a pandemic, decentralized services or not, or it's a suicide mission. We want to talk about the vaccination campaign in Europe, how is working, and what can we do to make it faster. Of course, we will be tackling also taxes on our healthcare because they are not only a barrier, but they increase the costs of our health, which is an essential factor for all of us. We are going to talk about rationalizing our services and what are the best solutions in order to give our society in Europe the best services at the best price. And of course, we are going to try also to tackle a bit about new technology, globalization, the freedom to choose, the capacity to benchmark as a powerful tool in the hands of the people. For public administrations and political authorities, let's say, were forced by this pandemic to improvise, but at the same time, they were also happy, to intervene our liberties, to intervene our healthcare with consequences that were quite grave in the case of Europe. We are counting more than 1 million deaths. So I think that it is time that we sit and analyze and take the blame as European Union, as continent, as a society for what has happened, and try and move forward and see what are the best recipes, what are the best solutions. And we know as libertarians and classic liberals that those solutions come generally from free market initiatives, from the private sector, and not so much from the state interventionist policies that both politicians at the EU level and in our countries level made us to believe. So in order to start this panel, I'm going to ask Morgan from Adam Smith Institute to give us a little bit of a heads up and explain to us her main important points of this discussion. So Morgan, please, you have the floor.
Thank you. Hi, everyone. I'm Morgan Scholdemeyer, the head of external affairs at the Adam Smith Institute based in London. And I just want to talk through kind of two main things that I think we can all identify with in all of our different healthcare systems. So I don't want to make any kind of broad sweeping claims because we all have different systems throughout Europe. So I'm going to use COVID as a mirror. And I know we're all kind of tired of talking about COVID, but you can't have this discussion without mentioning COVID. I'm going to talk about how COVID has been a mirror to kind of, as Roxana said, kind of shows what works and what doesn't work in all of our systems. And so I'll be using the UK as the example. The first thing to know here whenever we discuss the NHS is the NHS is seen as like a religion. It's kind of hard to have discussions about it because it's so exalted as a part of our culture. So that's an important thing to remember. When COVID hit, the messaging was all around how we need to protect the NHS. We need to all stay home to protect the NHS and make sure that, we can remain safe and keep our healthcare system working. And that was fine healthcare messaging in the beginning because we were looking at what was happening in Italy around the same time in March of 2020, and we saw what could happen. So this messaging was fine. But at the same time, we insist on separating the government and the health service into two separate bodies. Everything that is done poorly is the fault of the government, and everything that is done well is by virtue of the NHS. So you get this strange juxtaposition where the NHS is a thing that needs to be protected, but also it can do everything all at once. So what I want to mention are two things that I think are a feature of healthcare services that they're not bugs, they're a feature of the system, but they resulted in poor outcomes, especially in COVID. And that is heavily centralized healthcare systems and systems that rely very heavily on rationing. The UK is both of those. We have universal access to healthcare, so we have to ration through other means. That's normally waiting times or quality adjusted life years, which is how we determine the effectiveness and the efficiency of drugs. And then also it's a heavily centralized system. So again, they want to do everything. And when we're looking at COVID, you can see it's pretty clear the times when the UK failed and when they succeeded. When the government, the Department of Health, Public Health England, and the NHS all wanted to keep the COVID response centralized by designing their own tests and only running COVID tests through Public Health England labs, following kind of traditional non-crisis procurement procedures for things like PPE and ventilators, they failed miserably. We couldn't get enough tests. We didn't have enough PPE. All those things failed. But when the UK opened up to testing by private labs, was welcoming involvement of universities and charities to accelerate testing, this is when we saw that progress was being made. You can see the same thing with vaccines. UK universities partner with private companies, not the NHS, to develop the vaccines. So that's another example of a decentralized success. And then in terms of rationing, I guess we can get into this more later. The ASI has a paper recently out on rationing, and it basically points out that when you have a finite resource, which you do with healthcare, you have to figure out how to ration it. And in COVID, we rationed it by just not letting people use the service if they were non-COVID patients. So things like cancer treatments, a lot of maternal care, palliative care, that's all pushed to the side to make room for COVID. And again, I think these are both features of the systems, not bugs, because the UK doesn't have very many beds per capita, doesn't have enough doctors, it doesn't have these things that other European healthcare systems have. And that's kind of a feature of the system. And yeah, so I guess my point I want to keep in mind throughout this conversation is the idea of centralized versus decentralized healthcare and response and the impact of rationing on services. And that's kind of my brief introduction. I'll let Christian come in with his chairing and we'll get back to Roxana, but happy to be here and looking forward to answering some questions.
Okay, thank you, Morgan. I guess I'll have to do some retroactive chairing now. Yeah, sorry about the confusion. I guess this is one of the joys of the Zoom age, that you have people operating across multiple time zones. I thought it was going to be an hour later. So this is one of the things that don't happen in real life events, or at least hasn't happened to me so far. Yeah, I was just going to say, I do remember that I was on an Atlas panel last time, the last Atlas conference. And even though this wasn't that long ago, about 8 months or so, it was in autumn last year, it was a panel on a similar topic, but I nonetheless think it's fair to say that this is going to be a completely different panel today, because the situation has changed so radically in the meantime. Back then, we were in the early stages of the first wave, the second wave. So we had case numbers rising exponentially. We had hospitals filling up quickly. And we had death rates going through the roof. We had just entered a second lockdown. And the idea of vaccine was sort of vaguely talked about, but it still seemed like a long way off. And look where we are now, 8 months later. We now have half of the population of Europe vaccinated. In Britain, it's more than 60 million. And things are opening up, and we are clearly getting somewhere, even if it is in some respects still frustratingly slow. And that means we're now in a completely different situation. We can now talk about what went well during the pandemic and what didn't, which healthcare systems rose to the job and which did not. We couldn't have done this last time because it was halftime. It was too early to really say anything. Now I think we're already seeing the outlines of the final results. And it also means we can now finally go back to talking about conventional healthcare. You know, healthcare isn't just COVID, but it would, and on the last panel, the last conference, it would have been absurd to try to talk about anything other than COVID because the pandemic just crowded out absolutely everything. And we're now slowly moving back to talking about the normal issues, the long-term challenges that our healthcare systems were already facing well before COVID. And to that end, could I just ask both panelists, well, I guess you've introduced yourselves in the meantime, so we can skip that bit, but could I just ask both of you to give me your assessment of how your respective countries of residence have been coping with the pandemic overall? If you had to say rank it on a scale from 0 to 10, where would your healthcare system be? Morgan, if you want to go first, or yeah, sure, Roxana.
Okay, so on a ranking from 0 to 10, let's say, or from 0 to 10, Spain ranked in the first 2 waves around 2, let's say, and I'm being generous. And then in the second, and then in the third and the fourth wave, let's say that we pushed a little bit and we try and compose ourselves. And we are ranking around 4 to 5. Nevertheless, we are still suspending. This is the key issue that we have to take back home and reflect upon and start making amends. But I would like to make some initial presentation, then we move forwards to all the data, and we try and do some roadmap on what can we do in Europe, in UK, in Spain, and in general in the European Union to move to a better scenario for our NHS all across the continent. So we have to understand that in any society, human relations are based on the ideas of exchange as a primary basic market principle. We exchange goods, we exchange services, information in order to achieve what we want individually to make our life better. The same principle applies when we acquire clothes or food, for instance, which is an even more essential factor in our lives. If we don't eat, we die for sure in several weeks. Not even the best healthcare can bring us from the dead. All we do in this life is to pursue our own happiness as human beings, and this cannot be achieved if individuals are not free, prosperous, safe to achieve that happiness. Therefore, our society will be dysfunctional. And this primary basic market principle applies to our health services also. Market incentives depend on best serving the public needs, demands, and interests. Patients receiving treatments are satisfied with the services for the price they paid, directly or through taxes. And if they are not satisfied, they know they can always go to treat themselves elsewhere, and they will speak to others and badmouth mediocre services for sure, so that many others won't go there. That if we have free market healthcare system in Europe, which we don't have. But if we are stuck in one single state-run system known as the public healthcare or the NHS in most of our countries, we can't go anywhere, we can't escape. Instead of forcing everyone to use only the state-run system, as it has happened during this pandemic in Europe, and Morgan stated it in her initial intervention, Why not be ambitious this time and push reforms to guarantee the universal access for people to the best healthcare services provided by the society, the market, as is the case of essential goods and services like our food? If countries like Switzerland or Taiwan did it and their population has universal access to independent private healthcare services, so can we. Actually, we can learn from their do's and don'ts. We can be smart about it and pick the best solutions for our own reforms. So with that in mind, in Spain, during the first wave of coronavirus, our foundation sought the opportunity to sweep the Overton window in favor of a private healthcare sector, while there were credible threats to nationalize it, at first under the excuse of the COVID, and that didn't succeed because the state-run healthcare system collapsed in just 2 weeks. This could be a Guinness Book record, you know, because of the pressure of dealing in solitary with the wave. Why? Because the government prohibited specifically private services to intervene and help. So because they were trying to, because of their ideological blindness, to weaken the private services. And if that didn't went well, of course, they thought, oh, let's raise a VAT tax from 0 to 21% for all the health insurance plans. This could have affected 11 million users of healthcare services in the middle of the first wave of the pandemic and the second one. That is the third part of the Spain population, so that you can imagine. Under this situation, we reacted by producing 2 studies. I have them here, this one on deregulation and this one on tax reforms for the private healthcare. And of course, we made a huge effort. We sent our finding to all the parliamentary groups, regardless of their ideological orientation. This was beyond that. And all the health authorities at the state and regional level with our recommendation of reducing the normal VAT on face masks, which had happened. Unfortunately, it is now ultra reduced to 4% against in favor of reducing bureaucracy and waiting lists for foreign medical professionals, title recognition. Before this crisis, the process took 30 times slower than afterwards. So that proves that where there is a will, there is a way to reduce red tape. We worked on promoting the digital prescription to be expanded as a general rule, not as an exception. And now it is a generalized tool in our country. And of course, through our private healthcare saves lives campaign, we opposed the imminent raise of this new VAT on health insurances by the government. And finally, we worked also with the ombudsman against this issue. And in autumn, the government decided that it was not such a good idea to raise 21% all the health insurances for 11 million users in our countries. So this shows that if we take the opportunities that this crisis has given us, we may move this Overton windows towards our position of more opening our market, our healthcare market, to incentives from the private initiative. So I believe this is one of the main important key lessons that we have to take back home from this crisis.
All right. So a 2 out of 10 for the first wave, 4 out of 10 for the second wave. Okay, yeah, that's that sounds about right. I know that Spain had similar death figures to Britain. Morgan, how would you evaluate the way Britain and specifically the National Health Service have coped with the crisis?
I'd probably have to go similarly low to be about a 2 all the way through. Again, you say we have similar death rates, but my bigger issue, and you say specifically with the NHS, but I don't agree that we can disentangle the NHS and Public Health England and the government. I don't like this whole everything that's good is the NHS, everything that's bad is the government, because they are intertwined. Government decisions impact the NHS and likewise. So I think a few major errors that we experienced went back to the centralization, wanting to keep everything in-house, refusing outside help. You can kind of juxtapose the testing earlier in the pandemic with the vaccine, later in the pandemic, to see how this centralized versus decentralized approach can differ. So with testing early on, there was absolutely no outside help. They were running all of the tests for the entire country through 1 or 2 centralized labs. Results took days, if not weeks, to get back. And that would have been a critical moment that we needed to bring in private labs to create their own tests, universities to process the tests. There were labs all across the country that were coming forward saying, we have the staff, we have the equipment, we have the capacity to help, please let us. And Public Health England and the NHS and the government all together decided that that was not the best way forward. Had they allowed testing earlier on, we probably would have had a much more effective testing and tracing mechanism, which could have lessened the first wave. So those decisions made a big difference. And if you look at the vaccine rollout, our vaccine rollout was great in the beginning because they did the exact opposite. They allowed for universities to help. They opened up these massive vaccine testing centers in unused hotels and hospitality venues. They opened up the private sector. They allowed volunteers. Their manufacturing was outsourced to all different types of factories. So that was very successful. We got a ton of vaccines really quickly. We got a head start. Another reason why we got a head start on vaccines is because we didn't bother negotiating on price the way that the EU did. The companies were offering vaccines at cost. That's good enough for us. I mean, it's even better than we could ask for. We'd be willing to pay for these things, right? And European countries wanted to negotiate even lower. And that was something that was a misstep for a lot of European countries, and another reason why the UK got a bit ahead. And another issue that we faced was the decision to, again, protect the NHS, conserve resources, and offload elderly patients into care homes, but without testing them. So they were not tested for COVID. They were offloaded into care homes, carrying COVID just to empty up space in hospitals, beds. And there was like an excess of 30,000 deaths in care homes just from COVID. So these decisions, outlined to keep things centralized, outlined to protect the NHS from COVID, resulted in excess deaths and missed opportunities and things being slowed down because there was a resistance to any sort of outside help, resistance to change. And Roxanne is a lot more hopeful for Spain than I am for the UK. I don't think this is going to be a lesson learned. I think it's just we're just going to keep saying that everything that went right was the NHS and everything that went wrong was the government. So I'm not particularly optimistic for reform. But
yeah, so that contrast is interesting. You had business as usual during the first wave and with the testing and terrible results, and then something quite different from that with the vaccine rollout. Suddenly, this usual ideological aversion to bring in private sector actors, that was suspended, and it was now fine. It was all hands on deck, and we have to throw everything at that, and the results so far speak for themselves. But we don't hear it usually presented in those terms. It's often presented as, oh look, the NHS, how brilliantly it's doing, vaccinating everyone rapidly, and this shows that that we were right all along. One of the issues that the pandemic has clearly highlighted is the issue of rationing in healthcare, which of course happens all the time. We just normally don't acknowledge it very explicitly, but the mere fact that something is in principle available for free at the point of use doesn't, of course, mean that you can easily access it. And if that wasn't clear before the pandemic, it should definitely be clear now. I mean, anyone who tried to get a doctor's appointment or something for something other than COVID will have realized that there were major barriers to access, even though none of them had anything to do with money. Nobody in Britain or countries with similar systems ever says, oh, I would love to have this treatment, but unfortunately I can't afford it. That's not the way it works, but nonetheless, you just ring them up, or you check the app now whether there's any free appointments, and you just realize, no, this is not going to happen. I haven't seen a GP throughout this whole time, and possibly will not see one for quite a while. Can you both tell me a bit about how rationing works in the systems in your respective countries of residents? How does it manifest itself, and are there any better options?
So if you want, Morgan, I can start with Spain. In Spain's case, let's say that they finally, at the NHS level, discovered this called internet and new technologies and apps, and that actually work, because normally the websites of our ministries are very, very, complicated, and they are not user friendly. But this crisis forced them to start applying this modern technology. And of course, they discovered that, yes, we have to rationalize, and in order to be efficient and to give services to a wide range of population in need. But that costs us about more than 6 months to start rolling all the services. And even now, there are a lot of dysfunctionalities at the state-run service. I mean, because the private healthcare sector in Spain was already way ahead the public, the so-called public healthcare. They were always already using, from many years ago, digital, consultancy, phone call with your doctor if you weren't well enough to go to his practice. And that, let's say, opened a wide window of opportunity for the public servants in the healthcare. Even so, even introducing these elements, the problem is the system is so bureaucratic. There is so much reporting and red tape in the middle that you have, waiting lists for normal illnesses, for chronic disease patients, let's say, of 1 year, 11 months before you get your online or phone call consultation with your doctor. Additionally, we have, I don't know if in the UK happens the same or in other European countries, but here, for instance, you have to have public health doctor going over the diagnosis that the private one made for you in order to have access as those with your recipe, with your medical recipe, to go to the pharmacy and have your deductive treatment. Because if not, you have to pay a lot, even if you already pay taxes for this service, which you don't use normally, because as I was telling in my initial intervention, there are 11 million users in Spain that use primarily healthcare, private healthcare. Out of them, and this is important, there are 2 million of public servants, which are the only ones allowed to choose whether they pay taxes to go to the NHS system or they choose to have their private health insurance. The rest of us are forced to pay double. If you want to have your private health insurance, you pay your private health insurance, but on top of that, you have to contribute and pay taxes for the NHS system, which you don't use. So there is not much margin there to try and make them understand about the importance of a rationalization of healthcare. But it has opened at least a small window. Unlike you guys in the UK, I have some sort of hope, rather than optimism fully, that this is going to move in the right direction on a very long term.
Well, yeah, that could be, the reason would then probably be that even though Spain has a somewhat similar healthcare system to the UK, I don't think what doesn't exist there is this religious attachment to the system. I guess people would defend it, but not in a way that you would get socially ostracized if you said the system isn't performing well.
It's different. I mean, before the pandemic, yes, you would be socially ostracized completely. Anyone who speaks, who even questions, not critiques, but questions a little bit, the NHS, it's the devil at least. But with the crisis, that's why I was telling you that it was, you know, a kind of an Overton window for us. People at the beginning, I mean, can you imagine? People were applauding for the healthcare NHS professionals. In the first, they were going at 8 o'clock every day in the first weeks of the pandemics, applauding and enchanting to encourage the NHS public servants to maintain their positions in the hospitals. It was madness. But then
sounds familiar.
and but this also happened because there was a very, very controlled mass media message by the government in the first wave of the pandemics. We didn't see any casket, any dead people piling up in the first months and a half of the pandemic. People, it was like, you know, you were living in a bubble. You only heard the sirens all over, but people didn't actually realize what was happening, because both private and public TV stations, radio stations weren't saying anything or weren't showing really what was happening. They were only speaking about numbers, relativizing the issue, but they didn't show, you know, the reality. Why? Because at the same time, the main measure that the government did back then was to pump them millions of euros to rescue those public and private mass media. But afterwards, you know, the narrative changed when finally all those dead people, the families, started to realize that was our window of opportunity, and we started to work on raising the awareness on this system. And moreover, this issue, it is important that many people that before the pandemic were, you know, in favor of having only NHS, we have the best system ever, discovered, wow, the private system works far better. I'm asking for for a consultation, and they are giving me the consultation for 2 days ahead, not 1 year ahead. So it was like, you know, a myth was already melting. But I'm afraid that, you know, people tend to forget easily when things move to another stage. So we have to keep working on this narrative onwards.
Okay, yeah, the clapping ritual, that was definitely the exact same thing here. The difference is in what happened afterwards, that here, this whole attachment to the health service grew stronger over time. And I'd say, if anything, the Overton window has shifted in the wrong direction since then. But Morgan, to go back to the issue of the reality of rationing, what can you tell us about how this works in the system here?
Yeah, so I think I'll touch on the COVID after just describing how the rationing works here. So NHS doesn't charge for services other than tax. You can pay some small amounts for prescription drugs, but mostly rationing is through waiting times and through the NICE qualifications guidelines. So NICE stands for National Institute for Health and Care Excellence, and they're the ones who determine what treatments will be offered on the NHS on a cost benefit analysis. And the benefit is quality adjusted life years. So if the medicine gives you enough quality adjusted life years for not too much money, the NHS will adopt it. Christian himself has said in his research that one of the reasons why the NHS takes up a bit less funding than maybe some comparable European countries is because they don't use expensive drugs. NICE and the NHS will not offer some drugs which are determined to be not efficient. So one of the big ones was a cystic fibrosis drug, which costs hundreds of thousands of pounds for quality adjusted life years. But it's readily available in many other countries. The NHS just said it was too expensive, and so they didn't want to give it to all these people that would die without it. So that's one way that the NHS rations, and the other is waiting times. And this is probably something that is most familiar with people who are accessing healthcare in the UK and probably anywhere in Europe, is your waiting time. So your referrals for private consultations, your waiting times for non-urgent treatment, like a knee replacement or a hip replacement, So the NHS, the UK, ranks really poorly on all of these waiting times. Our A&E waiting times are apparently average, although you could spend 8 to 10 hours in an A&E waiting room if you're unlucky. The target is 4 hours. So waiting times and what treatments are available. Now, waiting times is going to be the big issue post-COVID, because as Christian mentioned, as I mentioned earlier, all non-COVID healthcare has basically been stopped. So a lot of people have already died because their palliative treatment or their cancer treatments were suspended because they weren't allowed to get chemo. Maybe they had a couple months left, but they were still getting chemo. It was their right to access that treatment if that's what they choose to do. They were denied that care. So that is something that I think is a huge reckoning for the UK, and it's going to be a massive strain on the UK moving forward, because all of those people need to access healthcare eventually. All the people that haven't been going to their ophthalmology appointments, all the people that want to have babies, all the people who might experience symptoms of cancer. These people are going to have to get healthcare at some point, and it's going to be a flood. And the NHS is not going to be able to. They can't handle it in normal times. They're not going to be able to handle a backlog of 18 months of care. So it's possible that we might see some people like myself who wouldn't normally pay for private healthcare because I'm a fairly healthy person. I don't have private health insurance, but I will probably pay for private if something goes wrong, because I know I can't wait 18 months or a year, So we might see more people buying private if they can afford it, more kind of middle-class people as opposed to only the richest. And that could result in some positive recognition that like the private sector does have a role to play in lessening the burden of the NHS. But again, I'm not terribly optimistic, just because, like Christian said, we've come around to appreciating the NHS even more than we did before. But I think Roxanne made a really good point about technology and incorporating kind of disruptive technologies into healthcare. So I know they've had a lot of success in the States with telehealth and getting apps, and you can access GPs on demand, basically, for a small fee. So I hope that picks up and more people take that on board. I think people in my generation certainly will. We're obviously very tech inclined in the first place. So it could be something that we adopt more readily. So I dread to think how we're going to deal with the COVID backlog of non-COVID related illnesses, but I hope that people will be open to using the private sector and taking that opportunity where they can, so that we can, first of all, get the treatment when we need it, and also kind of create this culture where it's okay to go private, even if it does cost more money.
Yeah, I'm not entirely sure what the best alternative to government rationing would be, because in healthcare, even though I'm a free market liberal, I would not be comfortable with a system in which access to healthcare is determined exclusively by ability to pay, or even mainly ability to pay. But there are ways of being less reliant on just government rationing. In some of the continental systems, for example, you have a system for new drugs, certainly, which is called a reference pricing system, where you can have a standard drug that is covered, or standard treatment that is covered by the statutory system. And if there is a newer, more expensive version available that the standard healthcare system wouldn't consider cost effective, what you can do is you can buy that, and the money that the standard treatment would have cost, you can get that refunded. So that would count towards, and you just pay the difference. You just pay for your top-up treatment. So yeah, ability to pay plays some role in such a system, but it means that it's not limited to the very richest. You can still carry over a lot of your entitlement that you have in the standard healthcare system towards purchasing private alternatives, and in that way you get a more open system. But speaking of that, Roxana, you said we don't have free market systems in Europe. Are there any systems that you would consider a second best, or approximating a market system? Because there are big differences between European healthcare systems.
Yeah, exactly. I mean, if we must learn, and we definitely should learn something important in terms of policy reforms from this crisis, is that we need to get the state out of the management of our healthcare equation. We have to give them, for the people that cannot afford to pay directly a private healthcare service, therefore to choose freely on the market between several services, we have to have, let's say, a subsidiary role of the state that is only a financial tool, giving those specific individuals with lower incomes the possibility of paying for their health insurance, but choosing, not robbing them from that liberty to choose among the services as the rest of us. And with that in mind, we should look at the Switzerland model in Europe. So we have here in our continent a model that we could try and emulate in our countries. Moreover, we can look at their do's and don'ts, as I was saying at the beginning, and apply, because they have been functioning with private healthcare for many decades now. And of course, because we are in the global world, we can look at other models also. We can, for instance, study and apply some of the recipes that South Korea is applying to their health insurance system, which is mainly composed of private hospitals. They have several NHS hospitals, but merely for investigation and as a university for students studying medicine. And moreover, we can look at the Taiwanese NHS, which is completely privately managed. That is, we can be ambitious and tell people, do you want your healthcare to be run by bureaucrats and politicians, or do you want your healthcare to be run by you, to be controlled by you? Let's give them, for instance, shares of our NHS to every citizen in our country. And afterwards, let's liberalize the market and open for them to do what they want with that share. Many of them, for instance, they are going to organize the hospitals as cooperatives, others as foundations, others as companies. We already have those functioning for the private, part of our healthcare. Why not generalize it if it is already working and it is having amazing results in comparison with the NHS? I mean, in terms of rationalization of waiting list in Spain, for instance, you have the long waiting list you have to wait in the private healthcare for a very complicated situation are 30 days. In our NHS systems, at best, you have to wait around 150 days for normal, not so specialized treatments. So we have the means. Let's apply them and not leave our people unattended and dying, literally, not only of COVID, but as we've seen of many other illnesses that have been left out during this past year.
Okay, so at least get the government out of healthcare provision, if it has to be publicly funded, then through single payer, Taiwan, South Korea style system.
Not manage, let out the government out of the management of the healthcare. This is the key issue. Not so much, we all agree that there have to be universal access to healthcare. It's human and it's very important for us, for all of us here. But this doesn't mean that you have to put government managing the hospital, the clinics, the waiting lists, the drugs that is administering, deciding the politicians which drug you should administer to the cancer patients, as it is occurring now. We've seen that with other essential aspects of our lives, which is, for instance, food, when we had it managed by the government in the Eastern Europe, we were, waiting in line, suffering from hunger for decades. And now it is happening the same with our healthcare.
Right.
It matters.
Morgan, do you have a favorite system? Is there, or is there a second best, a next best thing? Is there something somewhere in Europe where you'd rather go compared to what we have now?
I would just absolutely echo what Roxana said. And I think, especially coming from myself as an American in the UK, we get into this kind of false dichotomy that it's either completely state provided healthcare or US style system where people don't have access to healthcare. Healthcare bankruptcy is a real thing. And yeah, the quality of the service is great. If you can get it, the hospitals are top notch, some of the best doctors in the world, developing world leading drugs. But if you can't afford it, you don't get it. And we don't want that either. So I think Roxana is absolutely right. One of the easiest things to do would to have privately run hospitals. So you have experts who know how to run a hospital and can actually focus on the practical issues at hand at this one hospital, as opposed to trying to run a country of varying needs and demographics. So yeah, bringing it away from the state in the provision. I don't want to keep repeating Roxana, but I absolutely agree with what she said. And I think a problem with the debate is that we are often painted as a people who are trying to privatize healthcare and take it away from the people and bring it to a US style system. That's our big, Christian will know this. Christian did a report recently, and his IEA colleagues, I can see in the group, will recognize this. He did a report saying that the NHS wasn't that great at handling COVID, and he was attacked as someone who wanted people to die on the streets, basically. That's not the alternative here. And unfortunately, I don't think we can have, in the UK especially, and Roxana, you alluded to Spain as well, you can't have this conversation about bringing in alternative methods of providing healthcare without being tarred as inhumane or cruel or wanting poor people to not have access to healthcare. That's absolutely not what this conversation is about. So I think we as a group need to make sure that we continuously reiterate that it's not the US or the UK. It is, do we want Switzerland or the Netherlands or Taiwan or Singapore or Germany? Those are the differences, right? Not universal healthcare or no access. So yeah, absolutely agree with Roxanne on her thoughts on that, and just kind of bringing back to the broader point that this conversation can be productive as long as we do our best to make it so.
Sure, there are good examples of universal private insurance systems. You've mentioned the system in Switzerland. They've always had private insurance, but it's regulated insurance. They can't discriminate, and they have premium subsidies. So there is no such thing as an uninsured person in the Swiss system or in the Netherlands, and the results are streets ahead of what we get here. It's just that even if we could switch to that overnight, which I would immediately do if we could, but I'd say there's one problem that this wouldn't solve, and that is the issue of long-term increases in costs, because those systems are, well, in the case of the Netherlands, costs about the same. The healthcare spending is about the same as in Britain. Switzerland, it's higher. That's an issue which these systems are struggling at least as much with as state-run systems like in Britain or in Spain. So that is the one thing that a reform of that sort would not solve. Do you think we just have to accept rising costs in healthcare? Is this just a fact of life? Is it because demographic trends are working in that direction, and medical innovation keeps pushing up costs? Or do you think there are alternatives to that? Could we do something about cost escalations?
I think we definitely could do something about it, and it has to be with competition that always leads to excellence. It has to do to removing red tape, because many of those costs come from regulators. I mean, look at this crisis. We had, until we had the COVID crisis, for instance, to develop a simple drug, you weren't allowed, because there was a lot of prohibition and red tapes in the middle, to, for instance, do the clinical trials 1, 2, 3 at the same time. It was a rule from our point of view, and we questioned that in our campaign. It was a stupid rule. Why not work at the same time with the 3 levels of clinical trials. When you develop a new treatment or a new drug, you save time, you save money, and you reach the market earlier. So therefore, the patients get to have that treatment and or that drug earlier to treat their condition. Everybody wins, except, of course, the ones that are not interested in moving things so faster and lowering the costs, which is the bureaucrats and the politicians that need to intervene those processes. So there we have a point that we should work on in Europe, in all our countries, with the legislator and the regulators in general, and also with the healthcare services and directions, not only at the national level, because sometimes it's even complicated to reach them, but at a regional and more local level. Another point that we should engrave in our minds is that, for instance, for decades, we maintained a worldwide organization called OMS, Organization of Healthcare, that was supposedly created to deal with situations like the one we live. And what have they done this past year and a half? Rather than confusing, rather than hiding information because of their political games. And it's a structure that costs all of our countries millions of millions. Those millions, of course, are going and are reversing over our healthcare costs. We have to explain that to the people. So this we could rationalizing a bit and try and use the World Health Organization for its original purpose, not for political gains. Another thing that we should do is engage more with private sector pharmaceuticals in having them working more closely, not so much with the government, but with private healthcare services. That would reduce probably the costs that we have to pay. So I don't know, Morgan, do you have some thoughts on what are the solutions?
Again, I think I'm going second here. I'm just saying that everything you said is great, but absolutely agree. One of the things that we can do, well, again, so Christian says rising costs. So as an American, rising costs to me is rising costs of insurance, rising costs of drugs. But in the UK, it's higher taxes. So the NHS is costing more. They're just raising taxes to pay for it. So there's no desire to streamline in the NHS. There's no real impetus for creating more efficient processes and methods and using more efficient equipment or kind of upgrading. I think another issue is we don't have enough doctors and nurses. So kind of putting that money in to get your return on your investment with more doctors and nurses would help. But really it's without any sort of private push from any sort of competition, you're never going to see any impetus for change and any impetus for cutting costs where you can. I mean, the NHS is still the largest purchaser of fax machines. Who uses faxes anymore? Is these sorts of things that you can really make big improvements on bureaucracy-wise to cut costs, but there's just no. And if you suggest any of this, and we had this problem in the UK when they privatized hospitals by bringing in private cleaning companies and private providers of linens and things like that. They said that this was privatization. We were taking away the NHS and it was going to ruin everything. It's like, well, why should the healthcare service be responsible for cleaning hospitals or laundering linens or, doing any of these things, which could clearly be outsourced more efficiently and more effectively, but it's seen as an integral attack on universal healthcare. So those sorts of things are just so easy to do, and well, theoretically easy, but politically and popularly not so easy. So suggestions like that, yeah, making sure that we're outsourcing where we can to experts who are qualified to provide those services, and yeah.
Okay, so
Yeah.
the problem is a psychological, political one rather than a technological one. We clearly do see cost-cutting innovation in healthcare. It just doesn't seem to be happening in the Western world. It happens in emerging markets. India in particular, they've set up low-cost hospital chains. China, to a lesser extent, it can be done. It just doesn't seem to happen in Western systems. Anyway, unfortunately, we're running out of time here. Thank you very much, Roxana and Morgan. And to our listeners, apologies again for the confusion in the beginning. We could, I guess, go on for hours here, but if you're interested, check out the Foundation for the Advancement of Liberty in Spain, or the Adam Smith Institute in London, or of course, my own workplace, the Institute of Economic Affairs, and enjoy the rest of your conference. Thank you.
Thank you.
Thank you all.